Hello everyone, and welcome to our lecture on the immune system. This lecture follows up a chapter where we discussed how we protect ourselves from infections using antimicrobial drugs. And now, we're going to be taking a look at the mechanisms that are present within our own bodies, our natural defenses that are used to ward off infection. This natural ability to ward off diseases and protect against disease-causing agents is the definition of immunity. There are two different sides to the human immune system. Our innate or nonspecific immunity includes general defenses that are always present in normal, healthy individuals and can be used against pathogens regardless of type. So these are general responses that are not specific to the type of pathogen. The adaptive immune system or the specific immune system provides defenses that are fine-tuned to a particular pathogen and can be retained for future encounters. So in other words, our immune system has a memory, and that component of the immune system is classified as the adaptive immune system. These two halves of the immune system are divided into two chapters in your textbook, and those are chapter 17 and 18, and we are going to cover them together in the same lecture in sequence, starting by discussing the innate nonspecific immune system. Chapter 17. So, as we just said, the innate immune system provides us with general, ever-present types of defenses that can be used against any type of microbe. These defenses can be physical, meaning that they can be physical barriers to microbial invasion, and mechanisms that the body uses to remove microbes. Defenses can also be chemical in nature, meaning that there are chemical compounds generated in our bodies that inhibit pathogenic invaders. And finally, innate defenses can be cellular, meaning there are a variety of different types of white blood cells circulating in our bodies. These cells are also known as leukocytes, and they are involved in the direct destruction of microbial invaders. So in chapter 17, what we're going to do is divide the innate defenses up into these three categories and talk about them one by one, starting with the physical defenses. It should be obvious that one of our primary physical defenses to invasion by microbes is our skin. Skin is a formidable barrier to microbes because it is dry and it is salty, both of which are inhibitory to microbial growth of many, but not all species. It is also composed of tightly packed layers of cells, including an external layer called the epidermis, and an internal layer called the dermis. And the tight packing of cells makes it difficult for most microbes to invade by penetrating directly through the skin. We also have significant areas of mucous membranes that cover many of our body systems, including our respiratory tract, gastrointestinal tract, genitourinary tract, etc. These mucous membranes secrete protective mucus, and that mucus provides a layer, an additional barrier between the cellular material and the microbes. The mucus also is continuously sloughing off in a directional manner, and this too can inhibit microbial invasion. One area of our body where the mucous membrane exhibits this sloughing off activity is the mucociliary escalator present in our respiratory tract. The respiratory tract is covered in cells that produce cilia on their surface, which you may remember are tiny extracellular appendages that are used for movement. And in this case, the mucociliary escalator describes the manner in which the ciliated cells in our respiratory tract keep mucus moving in a defined direction towards our stomach, not our lungs. This is important because the stomach contains additional chemical defenses such as gastric acid that the lungs do not. So it makes sense to try to channel any invading microbes to the stomach and not to the lungs. Earwax, believe it or not, also represents a physical defense. Earwax is thick and sticky, which allows it to trap and inhibit microbes. The flow of urine allows microbes to pass directly out of the body rather than in. Vaginal secretion perform the same function. And then in our intestines, a phenomenon called peristalsis describes the unidirectional movement of mucus and other material through the intestines and out of the body. Peristalsis describes these muscle contractions that happen to pass material through the intestines and out the rectum. So next we have the chemical defenses. Chemical defenses includes oils that are produced by sebaceous glands on the skin. So not only is your skin dry and salty, it is also oily. And furthermore, that oil is slightly acidic, and this low pH further inhibits microbes from colonizing the surface of the skin. Many of our secretions also include a special enzyme called lysozyme. Lysozyme you may have heard before, and you may remember that it plays a role in breaking down bacterial cell walls. Lysozyme can be found in our perspiration, saliva, urine, and vaginal secretions. Gastric fluid, which is found in the stomach, contains hydrochloric acid and a very, very low pH. And then finally, vaginal secretions, earwax, and urine are all slightly acidic. So all of these further inhibit microbes in addition to the physical defenses. In addition to the chemical defenses that we just mentioned, there are certain classes of molecules that the body produces that are involved in the direct destruction of microbes. One of those classes is antimicrobial peptides. A peptide is a small protein. So antimicrobial peptides are short chains of amino acids that play various roles in inhibiting cell wall synthesis in prokaryotic cells, lysing their membranes to destroy them, and other mechanisms. The complement system proteins are a class of over 30 proteins that are produced in your liver and then circulate throughout the bloodstream. And they're named for the fact that they complement or enhance the action of your white blood cells, which is something we'll talk about in just a moment when we cover cellular defenses. There are also pro-inflammatory mediators. To be pro-inflammatory means to essentially promote inflammation. These are compounds that induce inflammation and the muscle contractions that drive phenomena such as coughing, vomiting, and defecation, all of which can eject microbes from the body. Cytokines are the final category, and these are essentially signaling molecules. They send messages between cells, and one of those important messages is that they can send messages to cells that have been infected by viruses in order to slow down the viral replication. And they also play a role in recruiting white blood cells to infection sites where they can go on to destroy the invading microbes. So this brings us to our final category of innate defenses, which are the cellular defenses. Cellular defenses, as we've said before, are mediated by leukocytes or the white blood cells. And one thing that's important to note about these leukocytes is that they are derived from bone marrow stem cells. The bone marrow stem cells gives rise to a wide variety of different types of white blood cells. As you can see here, the original bone marrow stem cell will differentiate into either a myeloid or lymphoid stem cell, both of which will further differentiate into erythrocytes, mast cells, monocytes, eosinophils, basophils, neutrophils, macrophages. As you can see, there's a wide variety. And we're going to talk about the roles that many of these differentiated white blood cells play, because each of them has a specific function. They all complement each other's actions, but some of them specialize in one type of microbial destruction versus another. Now, some of these cells are involved in the mechanisms of the adaptive immune system, but here we're only going to focus on the ones that are involved in the innate immune system because we're still within the confines of Chapter 17. Later, when we talk about Chapter 18, we will move on to those that are involved in the adaptive immune system. But the ones that are involved in the innate immune system include, number one, neutrophils. Neutrophils are leukocytes that migrate from the bloodstream into infected tissues, and then they destroy microbes through a process known as phagocytosis, which we will go over with in the next slide. Essentially, it is the process of engulfing and then breaking down microbes. Basophils are another type of leukocyte, but their role is different. What they do is they release a compound called histamine, which triggers inflammation and allergic response. Histamine, as you may recognize as being the root word of the drug antihistamine, when you take antihistamines, it's typically in response to an allergy. And so therefore, it makes sense to us that histamines are the class of compounds that generate those allergic responses. Eosinophil does play a special role in destroying parasites. They are the primary cells that go after protozoa and helminths. What they do is they attach to their surfaces and they release peroxides that are toxic to their cells. Mast cells, like neutrophils, migrate from blood to tissues, and there they release pro-inflammatory compounds that increase the level of inflammation. In just a moment, we'll talk about why inflammation is a good thing for the process of fighting an infection. Natural killer cells target and destroy abnormal cells. This can include cells that have been infected with a virus, or it can also include cancer cells. And they do this by releasing cytotoxins. This is a different mechanism than phagocytosis. In phagocytosis, cells are engulfed and destroyed. In the cytotoxic response, the cell will release these special molecules called cytotoxins that cause the microbial invader to essentially self-destruct. Monocytes are the last category of leukocytes involved in the innate immune system, and these migrate from the bloodstream to tissues where they perform phagocytosis, and they stimulate the adaptive immune system response, which again we'll talk about later in chapter 18, by releasing those special signaling molecules called cytokines. So now, as promised, let's take a look at this process called phagocytosis, which is one of the major ways by which white blood cells destroy microbial invaders. And you can see an animation of this happening right here. This is a neutrophil in the bloodstream, and around it you can see red blood cells. And you can see that it's chasing down a little Diplococcus bacterium. So what is happening here can be described as chemotaxis. Remember that chemotaxis is the process of a cell migrating toward or away from a substance based on chemical signals. So that's what's happening here. The neutrophil is exhibiting chemotaxis toward the foreign microbe. It then extends a pseudopod and uses that pseudopod to engulf the microbe. You may remember pseudopods from when we discussed amoebas, and that is the mechanism by which amoebas move. However, other cells are able to also extend pseudopods, and in this case, a pseudopod is extended and used to engulf this little Diplococcus. Once the Diplococcus is inside of the neutrophil, a vesicle forms around it, and this is a special type of vesicle called a phagosome. Its destiny is ultimately to fuse with a special vesicle called a lysosome, which also contains digestive enzymes that will destroy the foreign microbe. So this is essentially how phagocytosis works in a nutshell. Now, we also saw when we talked about these cellular defense categories that there were certain cells that increased inflammation. Inflammation is defined as a local response to an injurious agent that's associated with pain, redness, immobility, swelling, and heat. The reason why inflammation takes place is actually to facilitate the immune response to the site of that infection. When a pro-inflammatory compound is released and the inflammation cascade begins, the first step is vasodilation, which essentially means that blood vessels in the area dilate. If you think about what the word dilate means, when your pupils are dilated, they get larger. And so when your veins are dilated, when your blood vessels are dilated, they also expand. This allows a larger volume of blood to flow to the area, and in addition, it increases their permeability such that the white blood cells that are traveling in the bloodstream are able to more easily exit those blood vessels and move into the tissues where they can conduct their activities. So the purpose of vasodilation is to enhance the immune response, increase the permeability of blood vessels, and therefore allow the migration of leukocytes where they can perform phagocytosis. However, a side effect of this activity is all of the things that are associated with inflammation. The pain, the redness or immobility, swelling, and heat are all result of this activity happening, which again is meant to facilitate the immune response, but it can have some unpleasant effects on you. When inflammation happens on a systemic scale throughout the entire body, the result is fever or an overall increase in body temperature. There's evidence that lower grade fevers can assist in the immune response and therefore fighting infection. But fever can get so high that it becomes dangerous to a person. So higher grade fevers are somewhat counterproductive. So now we have a few checkpoints. Bordetella pertussis, which is the cause of pertussis, also known as whooping cough, destroys the cilia found on cells in the esophagus. So tell me, in what way would this compromise an affected person's immune defenses? And in this checkpoint, I'd like you to tell me an increased activity of which of the 6 leukocytes that we looked at would be associated with an asthma attack or anaphylaxis. So that completes our discussion of the innate nonspecific immune system, chapter 17. And now we're going to move on to talking about the adaptive or specific immune system, which I will remind you includes the defenses that are specified to a pathogen and includes the defenses that have an immunological memory. There are 2 components of the adaptive immune system. There's the humoral immunity and the cellular immunity. These 2 components have different mechanisms and they target different types of pathogens. Humoral immunity is primarily concerned with extracellular pathogens, so microbes that have invaded and are existing in areas outside of the cell. It is mediated by a special class of leukocyte called B cells, as well as antibodies. Cellular immunity, on the other hand, is dedicated to attacking pathogens that have invaded host cells, for example, viruses, and it is mediated by a different type of leukocyte called the T cells. So we're going to start by talking about humoral immunity, and then we're going to move on to cellular immunity. As we see, humoral immunity is mediated by B cells and antibodies. So what are antibodies? Antibodies, also known as immunoglobulins, are special proteins that recognize and bind to compounds present in pathogens that are called antigens. Antibodies are found on the surface of B cells, but they are also secreted by plasma cells, so they can either be attached to the surface of a B cell or they can be sort of free-floating in the bloodstream. What we can see in this depiction right here are antibodies that have attached themselves to antigens. And there's another component here that has been pointed out, and that's the epitope. So an antigen can practically be any part of a pathogenic invader. It can be a cell wall, it can be part of the capsule, or it can be part of the viral coating. It can also be part of their extracellular appendages like fimbriae or flagellum. And they can also be toxins that are generated by the pathogen. Furthermore, our bodies can sometimes react to antigens that are not pathogenic in nature. So, for example, an allergic reaction is your body's overreaction or hypersensitivity to a non-pathogenic antigen. But within an antigen, The whole antigen is pointed out right here. The epitope is the part of the antigen that is recognized by the antibody. So you can see here that the antibodies are binding to specific epitopes that are presented on the antigen. So if we think about the antigen as being like a person, the epitope is like the face. It's the part that is recognized. Most human antibodies conform to a structure that looks like what you see here on the slide. This structure is bivalent. Bi, the prefix meaning two, and it's called bivalent because it has not one, but two antigen binding sites that are identical to each other. One on the left side of this split and one on the right side of this split. The antibody, as we've said, is composed of proteins, but there are multiple protein chains that are involved in its construction. There are two identical light chains, named for the fact that they have a lower molecular weight. Here they are shown in green. And those light chains are accompanied by two identical heavy chains, named for the fact that they have a heavier molecular weight because they are larger. So the antibody is symmetrical. It has a light chain and a heavy chain on one side, and those are accompanied and bound to a light chain and a heavy chain on the other side. Together, those light chains and heavy chains create two identical antigen binding sites. And the stem of the Y here is called the constant region. It is also sometimes called the Fc region or the effector region, but we will choose to use the terminology constant region. Classes of antibodies are distinguished from each other based upon the construction of this constant region. And in just a moment, we will look at the 5 classes of human antibodies that have unique constant regions. But before we do that though, let's take a look at how antibodies work. You've probably heard a lot about antibodies and know that they are important, but you may not know the mechanism by which they actually fight pathogens in our body. There are a few different approaches that antibodies take to combating invaders. One of them is called neutralization. Neutralization is essentially where antibodies swarm an invader and bind to the epitopes on the surface, which prevents them from using those antigens to then attach to cells. By swarming and blocking those sites, the invader cannot use its protein spikes, its tail fibers, its attachment mechanisms to attach to a host cell and enter. Agglutination is another mechanism by which antibodies remove pathogens from the body. Agglutination describes the manner in which antibodies can bind to multiple pathogens at the same time, cross-linking them and creating these large aggregations. And once the large aggregations is large enough, it can be easily more filtered from the blood by your kidneys and spleen. A third mechanism is described as antibody-dependent cell-mediated cytotoxicity, which is kind of a mouthful, but it's usually abbreviated as ADC-CMC. And this mechanism describes how antibodies can bind to the surface of pathogens that are too large to be destroyed by phagocytes, so they're too large to be engulfed by our white blood cells, and so they require a different approach. Those antibodies can bind to such pathogens, and they can recruit natural killer cells which will approach and release those cytotoxins that then cause the cell to self-destruct. So as you can see, antibodies exhibit a wide range of activities that are dedicated to destroying pathogens. And while their antigen binding sites are highly specific to a certain type of pathogen, their constant region is what defines their broader functionality and sorts them into classes of antibodies, which is what we'll talk about next. The classes of antibodies are named with a consistent nomenclature of IG, followed by a letter. And the IG stands for immunoglobulin, which you will remember is a synonym for antibody. So immunoglobulin G, or IgG, is a class of antibodies that look like this, a very standard Y-shaped structure. They are monomeric, meaning that they remain singular and don't associate with other antibodies as some of these other classes do. IgGs are the most abundant class of antibody. They make up 80% of the antibodies circulating in the blood, and they are extremely versatile. They are also the only class of antibodies that can penetrate the placenta during pregnancy and pass immunity on from mother to child. IgM antibodies are a little bit different from IgG antibodies. They form a pentamer that is very effective at agglutination. Agglutination being the binding of an antibody or an antibody complex to multiple different pathogens and creating aggregates that can be filtered because they have become large enough to be detected by the kidney and spleen. So these IgMs have a different functionality than IgGs. IgAs have yet a different functionality. They form a dimer, so two antibodies that are connected to each other, and these are highly common to be found in mucus secretions. They play a role in trapping pathogens inside of mucus, and that mucus can then pass out of the body to eliminate the pathogens. IgD, these antibodies have the standard monomeric construction, and they are found on the surface of B cells where they bind to antigens. And in just a moment, we'll see the role that B cells play in this whole process. And finally, IgE antibodies. These ones are particularly important in allergic responses. They bind to basophils, which is one of the types of leukocytes, as well as mast cells, to initiate the allergic response. So here we have a checkpoint where I'd like you to label the parts of the antibody shown. We have parts A, B, C, and D. What is the name of each one? And just to be clear, in B and C, we are pointing to this component. The blue component is B, and the green component is C. Now, in this checkpoint, it has been discovered that women who receive the COVID-19 vaccine while pregnant are able to pass immunity onto their babies. So if a baby is born with immunity to COVID-19 after their mother receives a vaccination, which class of antibodies is involved in this process? Now, as promised, we need to discuss the role that B cells play because we talked about how humoral immunity is mediated by both antibodies and B cells. So far, we've only talked about antibodies, but we need to bring B cells into the picture because without B cells, there would be no antibodies. B cells are responsible for generating antibodies, and they're also responsible for retaining immunological memories in the immune system. So what antibodies will do is they'll play a role in activating B cells, and they will play a role in initiating those B cells transforming into memory cells. So let's take a look how that happens. As we saw, IgD antibodies are presented on the surface of B cells. And when those antibodies come in contact with an antigen produced by a pathogen, then the B cell will engulf that antigen and it will digest it, breaking it down into fragments, which will then be presented on the surface of the B cell. So we brought the antigen in, we've broken it down, we have presented a piece of it on the surface of the B cell. The B cell is essentially holding this antigen fragment out and asking for permission to essentially initiate an escalated immune response against that antigen. And so what will happen is a T helper cell, something that we'll talk about in just a few moments when we focus on the cellular immune system. A T helper cell will approach the B cell, recognize and bind to that antigen it has presented, and then it will give it permission by sending a chemical signal in the form of cytokines to escalate the immune response. So in this situation, the T helper cell is like the boss. It will come in, recognize the antigen, and then give the green light in the form of cytokines for the B cell to differentiate into plasma cells, and those plasma cells will then generate massive amounts of antibodies specific to that antigen, which then can go through the process of neutralization, agglutination, and all the other ways that antibodies neutralize chemical invaders. When B cells are activated, however, they not only differentiate into plasma cells, but they also differentiate into memory B cells, a special type of B cell that is covered in antibodies that will rapidly recognize the same antigen that has now activated it for future encounters. So this is key to our immunological memory and our ability to ward off infections that we have already encountered. This is why our secondary encounter or secondary response to a pathogen is much more effective, and we can achieve immunity to certain pathogens after we've been infected with them once. The primary response is everything that we've just seen through B cell activation, antibody generation, and encoding that immunological memory. Now that your body has those memory B cells, the secondary response will be much more rapid because the cells don't have to train and learn about that specific pathogen. They already have a memory of it. Antibody production upon secondary response peaks in 2 days, as opposed to 7 days for a primary response. So as you can see, it's so much faster. It takes half the time for antibody production to peak and that immune response to mount if you already have been exposed to a pathogen and have immunological memory of it. So this completes our discussion of humoral immunity, one of the two components of the adaptive immune system. Next, we're going to move on to talking about cellular immunity. But if you are looking for a good place to take a break in this rather long lecture, this is a good stopping point to take that break. If not, we're going to proceed forward and talk about the different classes of T cells that are involved in the cellular immune system. Because we did say that cellular immune system is mediated by T cell, which is another type of leukocytes separate from B cells, but still differentiated from the same bone marrow stem cells that all leukocytes come from, the different classes of T cells perform different functions. Helper T cells, as we've seen before, recognize antigens that are displayed on the surface of phagocytes as well as B cells, and then they generate cytokines that activate them and essentially give them permission to move forward with the immune response. So helper T cells play an extremely important role in the immune response because, as I've said before, they are essentially like the bosses of other leukocytes that give them permission to destroy invading microbes. Regulatory T cells also play an important role, but one that you might not expect. Regulatory T cells destroy T helper cells that are over-enthusiastic. Helper T cells sometimes are programmed wrong, and they can be too sensitive to antigens and components of the body that they should really not be reacting to, and this can lead to autoimmune reactions. They can cause reactions to normal beneficial members of the microbiome. They can also cause reactions to the fetus during pregnancy, both of which are major issues. So regulatory T cells rein in the over-enthusiastic helper T cells by destroying those that are programmed incorrectly. Lastly, the third class of T cells are cytotoxic T cells. These ones recognize host cells in the body that have been infected with intracellular pathogens, and they release cytotoxins to destroy them. So this is another different mechanism than the phagocytosis that we've seen. Again, it involves the release of cytotoxins that cause the cells, the invading microbial pathogens, to self-destruct. Like B cells, T cells need to be activated. Before a helper T cell is activated, it is called a naive helper T cell. It can become activated when a cell presenting an antigen, such as a B cell for example, will attract it and attach to it thereafter, which the T cell generates cytokines that activate the cell and direct it to escalate the immune response. So that's something we're familiar with. But what we didn't see is what happens to the T cell after this process, because it also becomes activated and differentiates into several different cell types. Effector cells are ones that stimulate cytotoxic T cells, macrophages, and neutrophils to conduct an immediate immune response to the pathogen. They also differentiate into memory T cells, and these memory T cells, similar to memory B cells, will record a permanent memory of the antigen that has been used to activate them for a faster secondary future immune response. So this is what happens when helper T cells get activated. Cytotoxic T cells can also be activated. So when cytotoxic T cells are activated, they too come into contact with a cell that is presenting an antigen. And once they have been activated, they start generating cytotoxins, in particular granzymes and perforins. Perforins are proteins that create pores in target cells, and granzymes are enzymes that enter those pores and induce something called apoptosis, which is the self-destruction of the cell. So this is the mechanism by which cytotoxic T cells will essentially be spurred into action and then destroy the invading pathogens. You may remember me mentioning that the cellular immune system is mostly focused on destroying intracellular pathogens, so ones that have already infected the whole cell. And this mechanism that is carried out by cytotoxic T cells is important because apoptosis allows for the destruction of host cells, human cells that have been infected with pathogens, without lysing them, because to lyse them and break them open would release the intracellular pathogens that are found inside. Apoptosis avoids this and allows the cell to be killed while the intracellular pathogens remain inside and are not spread, therefore, to other cells in the human body. Now, we've been talking about the role that T cells play in fighting infectious diseases, but they also play an incredibly important role in fighting cancer. And a very exciting area of research has recently taken off into the genetic engineering of T cells to identify and fight cancer in a more directed and rapid manner. This type of approach is called the CAR T cell therapy. It stands for Chimeric Antigen Receptor T cell therapy, and it is essentially involves taking a person's T cells out of their body, genetically manipulating them to teach them and train them how to identify their specific type of cancer that affects the patient, and then putting those T cells back into the body to destroy the cancer. This has been approved for leukemia and is being looked into for other types of cancers. But it is a very exciting therapy. And in the clinical trials of this technique for treating pediatric leukemia, it was found to be highly effective and eliminated cancer in 80% of the patients. And there's a YouTube link that I want you guys to check out that shows you how this new technique works. So I highly encourage you guys to check it out. Now, to cap off our discussion of the adaptive immune system, we want to look at the different ways in which adaptive immunity can be acquired. Adaptive immunity can come to a person naturally or artificially. To gain natural adaptive immunity essentially means that you gain that immunity in the course of your everyday life without medical intervention. Artificial adaptive immunity involves medical intervention. Adaptive immunity can also be passive versus active. Passive adaptive immunity is acquired when a person receives antibodies that have not been generated in their own body. Active adaptive immunity is acquired when a person generates their own antibodies in response to exposure to an antigen. So these different categories of adaptive immunity can mix and match with each other in different ways. For example, naturally acquired active immunity is when a person generates antibodies as a result of getting sick with a pathogen and then recovering. So this is a natural form of immunity, and it is active because their immune system generates its own antibodies. A natural form of passive immunity is when babies receive antibodies from their mother through breast milk or by antibodies crossing the placenta. It's natural because it doesn't involve medical intervention, and it's passive because these babies do not generate the antibodies themselves. They receive it from another person, in this case, their mother. Antibodies can also be received from a donor through medical intervention. So this is an example of an artificially acquired passive form of adaptive immunity. It is common to treat infections of tetanus and rabies with antibodies that have been taken from a donor and then are channeled into an infected person's bloodstream. Finally, artificially acquired active immunity is when a person receives a vaccine. It involves medical intervention, and it also involves a person's body generating its own antibodies in response to the antigen that they are exposed to in the vaccine. Now, vaccination and artificially acquired active immunity warrants a little bit more discussion and elaboration. But before we do that, I have 2 checkpoints for you. In this one, I have described 4 examples of adaptive immunity, and for each of them, I'd like you to classify them as artificial or natural and as active or passive. And in this checkpoint, what you're looking at is the ring stage of Plasmodium, the pathogen that causes malaria. We can see a sample of red blood cells, and inside of those red blood cells are the ring-shaped Plasmodium pathogens. Which part of the adaptive immune system, the humoral or the cellular, would target this stage of the Plasmodium infection? So as we saw, artificial active forms of adaptive immunity are acquired through vaccination, which is defined as the delivery of a substance that stimulates the production of antibodies. It is an extremely important way of preventing diseases and has had a massive impact on public health all around the world. To give you an idea of how impactful vaccination has been, in the 1900s, the disease known as smallpox killed 300 to 500 million people, whereas today, because of vaccination, smallpox is now eradicated. Smallpox is a viral disease that has no antibiotic treatment available, but because of vaccination, there are no more cases of smallpox in the world. Before vaccines, virtually every human contracted measles before the age of 15 because of how contagious the disease is. Today, there are typically less than 200 cases of measles every year in the United States. Before vaccination, 350,000 people contracted polio around the world every year, with many of them, particularly children, becoming permanently paralyzed because of it. Today, there are fewer than 100 cases of polio around the world each year. And before vaccination, rabies was a death sentence. There was absolutely no treatment for someone who was bitten by a rabid animal. They were going to die. And today, rabies is treatable with a post-exposure vaccine, and therefore rabies is no longer a death sentence. Vaccines are so impactful that, in combination with antibiotics, life expectancy in all regions of the world has doubled over the past 150 years. So this gives you an idea of how important vaccines are to public health. Vaccines can be formulated in a few different ways, and these are designated as different classes of vaccines. Vaccines may have a live attenuated formulation, which means that they contain a weakened strain of a pathogen. So they have the whole pathogen inside, but that pathogen has been modified and weakened so that it cannot cause a clinical infection. Examples of live attenuated vaccines include chickenpox, measles, mumps, and the typhoid vaccine. Then there are inactivated vaccines. Inactivated vaccines also contain the whole pathogen, like live attenuated vaccines, but that pathogen has been completely killed with either heat, chemicals, or radiation. Examples of inactivated vaccines include the hepatitis A vaccine, the influenza vaccines, and rabies. Then there are subunit vaccines. Subunit vaccines do not contain the pathogen itself, but rather an antigen, perhaps from the surface of the pathogen, which is good enough for your body to recognize it in order to mount an immune response. Examples of subunit vaccines are anthrax vaccine, human papillomavirus vaccine, and the hepatitis B vaccine. Toxoid vaccines are specifically used for diseases wherein bacterial toxins play the major role in causing the disease. They contain inactivated toxins, which are called toxoids. Examples of diseases that can be prevented with these vaccines are botulism, diphtheria, and tetanus, all of which have toxins as their origin. Conjugate vaccines are a special type of subunit vaccine which contains an antigen that has been attached to or conjugated to, in other words, a capsule polysaccharide. The purpose of this conjugation is to increase the immune responsiveness to that antigen. Conjugate vaccines were developed because sometimes in children under a certain age, they do not mount a strong enough immune response to a subunit vaccine by itself. And so by attaching it to another antigen, a capsule polysaccharide, this can increase the immune response and cause meaningful generation of antibodies in response to the vaccine. An example of a vaccine that is formulated in this manner is the meningitis vaccine that children receive. Lastly, mRNA vaccines contain a fragment of messenger RNA that encodes an antigen. It is your body's responsibility to take that messenger RNA and translate it into the antigen, and then it will mount an immune response after recognizing that antigen. The COVID-19 vaccines are an example of this class of vaccine. So now at this point, we are going to just barely dip our toes into one topic that I've pulled from chapter 19, which is disorders of the immune system. There are certainly a wide variety of disorders of the immune system out there, but we are going to take out of chapter 19 one of these, and that is acquired immunodeficiency syndrome, or AIDS. We are focusing on this one because it is considered a pandemic to this day and a major public health priority. Acquired immunodeficiency syndrome is a disease that may develop after infection with human immunodeficiency virus, or HIV. We are talking about this in conjunction with our immune system lectures because HIV selectively infects T cells, which we've just finished discussing as part of the cellular immunity. When a person is infected with HIV, either through intravenous drug use or sexual intercourse, they enter into a series of stages by which the infection can eventually progress to AIDS, but not always. Stage 1 is the acute infection stage. After a person is exposed to HIV, their viral load is extremely high. billions of their T cells become infected, which causes a sharp drop in their T cell count, but then it recovers. During this time, risk of transmission is high because the viral load is so high. However, tests may still come back negative. A patient is asymptomatic or may experience temporary flu-like symptoms during this stage. It occurs 1 to 4 weeks after infection and lasts only 1 to 2 weeks. After this, a person enters what is called the chronic infection stage. During the chronic infection stage, the rate of viral replication is low compared to the acute stage. However, T cell count declines steadily, and the person may experience early signs and symptoms that their immune system is struggling, including persistent yeast infections, diarrhea, and fever. This stage of the infection can last 10 years or longer, and only if it is not recognized and properly treated with antiretroviral drugs will it progress to stage 3, which is clinical AIDS. This is recognized as when T cell counts drop to 200 cells per microliter from the normal level, which ranges from 500 to 1500 cells per microliter. So before this point, a person is merely considered to be HIV positive. AIDS only develops when a certain threshold of T cell count is reached. It is during this final stage that cancers and opportunistic infections begin to appear. Some of the more common ones include fungal infections of the respiratory system, tuberculosis, and toxoplasmosis of the brain. So, as we said, AIDS is considered a pandemic. There are 38 million cases of HIV infections worldwide. 25 million of those are in sub-Saharan Africa alone. In the United States, where there are more than 1 million people infected with HIV, an estimated 13.8% of HIV-positive individuals do not know that they are infected. In 1/3 of the cases in Europe and Southeast Asia, the latter of which has seen a recent spike in HIV cases, are from intravenous drug use. It is probably no surprise to you, given the scope of the pandemic, that the treatment of HIV is a major public health priority. The development of a vaccine has been prevented by the rapid mutation rate exhibited by the HIV virus. However, there are a variety of drug classes that have been developed to very effectively treat HIV infections. These include enzyme inhibitors that target the viral enzymes reverse transcriptase, integrase, and protease, as well as inhibitor drugs that prevent the attachment of the HIV virus to the receptor on the T cell, which brings it in. There's also an interest in a possible future treatment involving a gene therapy approach that relies upon a naturally occurring mutation called CCR5 delta 32. A very small percentage of people around the world have a mutation called CCR5 delta 32 in the receptors on their T cells, which makes them resistant and incompatible with the HIV virus and therefore immune to infection. This mutation is very rare, but over the past decade, it has serendipitously and coincidentally resulted in 2 cases of HIV being cured, and that is through bone marrow transplants. There have been 2 cases of individuals who were both HIV positive and had bone marrow cancer, and received a bone marrow transplant from someone who had the CCR5 delta 32 mutation. This was completely on accident, but when they received that bone marrow transplant from the person who had the mutation, you may remember that bone marrow stem cells are the source from which T cells and other lymphocytes differentiate. So once they received that, the new T cells that they were differentiating were resistant to the HIV infection and they were able to be cured. Now, as I said, this is not something common that happens, and it's also not seen as a viable way of treating HIV infections because bone marrow transplants are dangerous. They are very hard on the body, they require immunosuppressing drugs, they have a rejection rate, and overall, they just are not a viable option for treating HIV infections, particularly because the drugs that we have for treating HIV infections are so effective. Antiretroviral therapy, or in other words, therapies involving drugs that fight retroviruses, have totally transformed the life expectancy of people who have HIV. Now, these statistics here come from Canada, which is a developed nation. And so it's important to note that in developing countries which have less access to these drugs, there is still a major problem with treating HIV. But as we can see, in Canada, upon the introduction of antiretroviral therapy, the number of HIV-related deaths plummeted. So, antiretroviral therapies are highly effective, and since the year 2000, they have resulted in a significant increase in the life expectancy of people who are affected by HIV. There is also an increase in the use of pre-exposure prophylaxis, or in other words, PrEP as it is abbreviated, for preventing HIV infections. This involves taking antiretroviral drugs proactively before contracting HIV if you know that you are in a position to potentially catch HIV. For example, a person who knows that their partner is infected with HIV, or a person who uses intravenous drugs and shares needles might seek out PrEP from their doctor to prevent acquiring an HIV infection. PrEP is 99% effective at preventing HIV infections from sexual intercourse, and it's 74% effective at preventing HIV infections from intravenous drug use. So these are oral tablets that people can take. But there is also interest in developing long-acting formulations. So long-acting formulations means that instead of taking a daily pill, you can get an intramuscular injection of an antiretroviral drug somewhere around every 2 months. So this is also a viable option, especially in parts of the world where regular medical care and access to clinicians is not as available. So finally, we're going to cap this lecture off with a checkpoint about HIV antiretroviral drugs. Elvitegravir is a drug that prevents the HIV DNA genome from merging with the T cell's chromosome. So how would you classify this drug into one of the 4 classes that we just saw on the previous slide? What type of inhibitor is it? And once you've finished this checkpoint, you're done with our lecture on the immune system.